Welcome to the Rocky Mountain MS Center's webinar series. This series is designed to give people with MS information to empower them to make the best choices for their lifelong brain health. I'm Kelsey Morrow, Education Manager at the Rocky Mountain MS Center, and I would like to thank the pharmaceutical companies who have provided support for this program. Thank you to Genentech and Novartis Pharmaceuticals. This speaker series is just one piece of our education programming. We have a variety of formats available to you, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. Some of the most recent videos we've posted are the presentations from our Fall Education Summit, which covered the differences and similarities between NMO and MS, research updates, addressing mobility concerns, the concept of progression independent of relapse activity, and cognition. There is also an archive of videos from Conversations on MS, which is a 90-minute town hall style Q&A with an MS specialist neurologist from the Rocky Mountain MS Center, and includes a clickable index of topics. Our most recent webinars covered topics of MS basics, cognitive functioning in MS, demystifying MRIs, and managing the financial risks of disability. We announce upcoming educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. All of our education programs are free of charge to anyone interested. Our next program will be our Spring Education Summit coming up on April 6th. We'll cover research updates, stem cells in MS, treatment philosophies, as well as the symptom spasticity. You can attend that program in person or watch online via Zoom. Today's presentation will explore the why behind MS, including genetic and environmental factors. Our presenter is Dr. Molly Moehlman. Dr. Moehlman completed her medical school training at the University of Texas Southwestern Medical School before going to the East Coast for her pediatric neurology residency at Children's National Hospital in Washington, D.C. She has been loving her time in Colorado this past year as she completes her Neuroimmunology fellowship at the University of Colorado and Colorado Children's Hospital. When she's not in the hospital, Molly enjoys spending time with her husband and cats and enjoys a wide range of activities, including hiking, knitting, and playing golf. This webinar does feature a lot of important information. If you missed something on a slide or you want to hear it again, we are recording it and it will be archived on our website, mscenter.org, so you can replay it at any time. All live viewers will automatically get the recording sent to them. You will also receive a link to our evaluation survey. Please take a few minutes to fill this out as it helps us improve future programming. We'll reserve time at the end to answer questions from the audience. You can submit questions at any time using the Q&A box on Zoom. We did have a large number of questions submitted at registration, many of which will be answered in today's presentation, but we'll answer as many additional questions as time allows. And today's presentation is for educational purposes only. With that, we'll turn it over to Dr. Moehlman.
Hi, everyone. Thank you for joining today. So nice to meet you virtually, and we'll get started. I'm going to get my screen shared. All right. So one of the most frequent questions we get is, what is the reason behind why MS happens? And that's what we're going to be exploring some in this webinar today. As Kelsey said, I'm a neuroimmunology fellow, so I'll be graduating from my neuroimmunology training in June of this year. My disclosures, I have my fellowship is funded by the National MS Society Clinical Care Physician Fellowship. So whenever we're diagnosing someone with MS, one of the early questions that tends to come up is, why did MS happen to me? And even later on in the diagnosis, this is a question that frequently plagues people. And it's a difficult question to answer at this time. We know that there are multiple factors that come together to lead to an MS diagnosis. So it's a combination of genetics, your overall autoimmune susceptibility, geographical location, previous infection risk, and other environmental factors, as well as factors likely we don't understand yet, that come together to make this perfect storm that leads to an MS diagnosis. Just a quick, what is MS? So when we think about MS, it's a neuroimmunologic disease. What that means, the neuro part, is it affects brain and spinal cord, so your central nervous system, avoiding the peripheral nerves, causing very neurologic symptoms. Immunologic means it's triggered by the immune system dysregulation, leading to attack of your own body system. And the target is myelin, so the insulation that protects nerve fibers and leads to disrupted signaling between brain and body. So without delaying too much, we're going to get into the genetic risks that we know of that affect MS. So genetics has been an interesting question of MS, and I think it's important to recognize how much of the population does MS actually affect. And this number is changing frequently as our diagnostic criteria change and as people are recognized earlier and with better accuracy. So this slide shows an image from the Atlas of MS, which is an international registry trying to understand the global prevalence of MS. So prevalence, for those who are not familiar, is how many people are living with MS currently. It's not how many people are diagnosed per year, but how many in total have the disease at a given time point. And you can see that based on the most recent data, 2.9 million people are affected and diagnosed with MS. That's gone up pretty drastically from the 2013 estimate, which was 2.3 million. And you can see, based on this image here, that there are different geographical regions that MS seems to be more prominent in. And so the areas that are in bright red or the darker red are the highest prevalence, with over 200 per 100,000 people. So over of 100,000 people, more than 200 people in those regions would have MS diagnosed. And you can see kind of some of the different areas where MS is not as frequently located, or still significant areas where MS prevalence is unknown. What does it look like in the United States? So up until 2019, when the most recent data came out, it was estimated that 400,000 people were living with MS. The 2019 data showed that this was a vast underestimate, and the number today is probably much closer to 1 million people in our country living with MS currently. That comes out to about 1 in every 300 to 400 people that have MS, or 0.3% of the US population. The Colorado prevalence is about 1 in 580. Now, this is a really interesting area of information, because Colorado for a long time has thought to have a higher incidence of MS. And whether that's still true or not, based on these newer numbers, is a little bit harder to pinpoint. There have been no clear data that has come out showing that altitude, or being in Colorado particularly, anything about the land or exposures themselves in Colorado have had a significant impact as to MS prevalence. And it's probably pretty close to the general US population, and was just better recognized for a longer period of time, when it was thought to be that MS was only the 400,000 people. So with that new change, Colorado is much closer to the actual US population prevalence in general. When we talk about genetic risk in different diseases, there are different ways that we can think of genetics. So there are certain diseases that we know, things like cystic fibrosis or sickle cell disease, that a change in a single gene guarantees disease activity. And that's not the case in MS. So that's why my first bullet point here says it's not directly an inherited disease, because it's not, we know that one change in one gene leads to the disease. But most likely it's that you have certain genetic changes that lead to an inherited risk of MS. There are over 230 genes that have been identified currently where mutations contribute to MS risk. Genetics has been a really interesting focal point of MS care for quite a long period of time. The first case reports of families with multiple relatives with MS diagnosed came out in the 1960s. And then additional research has been ongoing since then. You can see on the right-hand side of the screen, this picture showing where some of these different genetic changes localize. And most of them tend to affect the immune cells in some way, shape, or form. So genes that contribute to regulating B cells or different cells within the immune system. When those genes are mutated, those are the ones that contribute to MS risk. The strongest association has been known since the 1970s to be in the HLA group on chromosome 6. And 1997 was when the HLA-DRB1 haplotype that I have listed here was recognized and was found in research. This is the gene that has the strongest association with MS of the changes that we have found to date. And it includes about a 3-fold increased risk compared to the general population. So when we look at family dynamics with MS genetics, again, the risk in the general population is about 0.3% or 1 in 334 on estimate. We've looked at identical twins, so individuals with identical genetic composition, and seen what is their risk of both twins having MS. These studies were published in the 1980s in Canada. And the risk of both twins having MS comes out to about 1 in 3 to 4. So it's about a 30% risk of identical twins having MS. That comes out to about 100-fold times more than the general population. But you can see that genetics alone cannot be the cause of MS, as if that were the case, you would expect identical twins with the same DNA to have a 90 to 100% risk of having MS. So that difference, that 70% that's not explained, has to come from other places. A lot of families come in and ask, what's the risk of my loved one having MS, whether that's a parent, a sibling, a child. Many people come in without having any family members with a diagnosis of MS, but sometimes we do find families that have multiple other relatives with it, and what is that risk for them and going forward. That's known to be about 1 in 40 to 50 people, so a 2 to 3% risk in general, so about 10-fold higher than the general population. So is a higher risk, but again, if you have MS, your risk of your family member, a first-degree relative going on to have MS is only about 2 to 3 of 100 people would go on to receive that diagnosis. Because of the ambiguity of the genes that are involved in MS, the differences, and the fact that at this time, there's no clear link between genetic changes and prognosis or treatment, there's little role for genetic testing as a standard part of MS care at this point. So there are some research opportunities that I'll bring up at the end of the presentation, but not something that is typically done or would necessarily be beneficial as far as affecting prognosis or treatment for you if you've received an MS diagnosis. In the literature, there have also been studies to show are there genetic changes that can help predict which type of MS I may have, whether that's relapsing remitting or primary progressive. And so far to date, there have been no significant differences found between the genetics of people that are more predisposed to primary progressive MS versus relapsing remitting. And earlier this year, there was a new paper that came out in Nature looking at ancestry of MS genes and what are the reasons that some of these genetic factors may have developed, and can we figure out why they may have developed and where they came from. what you can see here is a couple of different diagrams looking at this HLA-DRB1 haplotype that is so well known. And so they were actually able to gather historic DNA samples from back to early Northern European ancestry. So over 4,000 years ago that you can see, and study different changes in genetic patterns. These first two graphs, A and B, these first two pictures, A and B, that you can see here, look at your current prevalence of MS within Europe per 100,000 people. And then it overlays with where step ancestry came from. And so you can see that many of the step ancestry data tends to overlie with where the higher risk of ancestry of MS in our current population came from. These other two pictures here tried to map out different allelic patterns and different genetic patterns to see, as things changed, where do things overlie. And again, in this step pattern is where we start to see more of the genetic changes that are associated come up. This shows time and when things arose and the population expansion. And so the step population, as you can see here, appears a little bit later. Looking at that HLA-DRB haplotype, they were able to map where the prevalence of that location occurred. And they were also able to then plot that out over time. So in this graph, farther back is to the right, and as we move closer to the present day, is to the left. And what's interesting about this graph is that these are of the historical samples that were collected. These are people who show the HLA haplotype frequency. And so you can see that the first presentation of that HLA haplotype frequency was around 6,000 years ago, 5,000 years ago, in one person in the Neolithic period in Italy. But then in this red box here, that's when the haplotype frequency really starts to increase. And that's when the steppe population really took over in those areas of Europe at that time. One of the thoughts leading as to why this may have happened is different infectious risks promoting different genetic susceptibilities. There were more interactions and different interactions between populations within that population, and leading towards different sharing of infectious risks. And it's thought that with changes in the immune system, people with MS may be at different susceptibilities, or people with those haplotypes, the genetic haplotypes may lead to different infectious susceptibilities that then, because it changes the immune system, also eventually leads to MS. The way they looked at this was to compare genetic haplotypes and genetic changes in multiple sclerosis to patients that had rheumatoid arthritis and look at some of these infectious triggers. And so you can see that rheumatoid arthritis are these orange bars, and MS is the blue bars here. And there are certain infectious triggers that seem to be more prominent that you can find basically sequelae of genetic changes in regards to those infectious changes that differ between MS and rheumatoid arthritis. They did some of the similar plotting that we showed for rheumatoid arthritis as well. And it happened at an earlier time period in different areas compared to MS, leading towards agreeing with that explanation that there may be an infectious component that drove some of these initial genetic changes. One of the other interesting genetic questions regarding multiple sclerosis and different immunologic diseases, as well as the difference between women versus men. In MS, we know that the ratio of women to men diagnosed with MS is 4-to-1. For a long time, it is thought to be potentially hormonal regulated, though there are new studies showing that in women who have two X chromosomes, one gets inactivated, whereas in men who only have one X chromosome, that inactivation doesn't occur. And in Nature earlier this year, that coding that leads to inactivation on the X chromosomes was shown to have increased immunogenicity, leading towards that increase of the immune system to potentially act inappropriately, which may explain why immunologic diseases are more common in women in general. All right, so that was a whirlwind of what we know for the genetics portion. All of that to say, genetics likely carries a portion of the risk of development of MS. It's thought to contain up to about 30% of your risk of development of MS based on those twin studies is kind of the highest risk possible, but it does not fully explain why MS occurs. So when we acknowledge that genetics cannot be the entire story, then it becomes what else can be involved and what are the other environmental risk factors that may contribute. One of the topics of interest is, are there different risk factors in different communities and ethnic backgrounds that may be driving MS? Overall, the modifiable risk factors seem to be relatively consistent at this time, but more research is needed to see in particular communities what those risk factors and what higher risk factors may be present. Latitude is a well-known risk factor, environmental risk factor for MS, and one that we've already touched on a little bit with the genetic history. So you can see from the picture that higher latitudes or farther from the equator is associated with higher prevalence of MS in general. We also know from studies that higher latitudes are associated with 2-year earlier onset of MS, so earlier diagnosis of MS in general. And that relocation, so if you move before the age of 15 years old, can actually play a role, and that you assume the environmental burden of the area that you move to. We know it for 15 because that's when the studies used as a time cutoff and kind of a marker point. So the exact time that changes is probably more on a spectrum, but at least from the studies, we know that if you move in childhood from a more southern area to a more northern area, that your risk of MS will increase. Vitamin D is one of the more interesting factors that is associated with MS. So, and I'm going to talk about vitamin D in a couple of different ways. I want to first touch on what is your risk of going on to develop MS. And so this was studied through the Nurses' Health Study 1 and 2 that were run between 1980 and 2000, where nurses enrolled in the study and were followed and were monitored with questions such as, you know, what is your diet? What kind of supplements do you take? Along with multiple other things that were followed, and then went on to look to see in that 20-year time period, what were the different rates of diseases that were present. And so in our situation, what were the risks of going on to develop multiple sclerosis? So from that study, we know that the relative risk of developing MS, if you compare groups that had high vitamin D levels versus lower vitamin D levels, that your risk of, if you were in the higher group, was lower, was 0.67 compared to the lower levels of vitamin D. So it seemed to be a protective effect with higher levels of vitamin D against development of MS. That was similarly shown if you look at who was actually taking a supplement. So if you were taking a supplement of 400 international units a day versus none, your risk, if you were taking the supplement, was 0.59 compared to those who were not. You can also look over here on the graph that I included, and it showed that looking at the different rates of vitamin D and the different quartiles of vitamin D, what your risk of going on to develop MS was. And overall, the important one to look at is kind of if you compare the really low group to the higher groups, that your risk was, your odds of going on to develop MS was much higher if you were in that low group for vitamin D levels in general. So that's your risk of MS. There's been a lot of interest as far as can vitamin D itself affect MS once diagnosis is made. And that's been looked at from multiple different levels, both normal levels of vitamin D as well as high levels of vitamin D supplementation. There are ongoing studies in some areas looking at whether or not super therapeutic doses or very high doses of vitamin D can actually be effective as treatment. So far, unfortunately, that data has been very inconclusive. There have been some studies that show that maybe it has an effect, and many other studies that show that, unfortunately, it does not have a significant effect on relapse rates or progression of MS when you're comparing normal vitamin D levels to very high therapeutic, very like over the therapeutic level of what we would consider normal vitamin D levels. There is some data continuing to support the use of vitamin D and that low levels may be more harmful. And so typically what is recommended is to keep those normal levels of vitamin D. The other issue with vitamin D is that normal levels of vitamin D is not going to cause any problems, but with very high levels of vitamin D, there is such a thing as vitamin D toxicity. And so things that can come from very super therapeutic levels or very high levels of vitamin D include kidney failure, kidney stones, bone loss, which is more prevalent in MS patients, especially as they age in general, fatigue, dizziness, confusion, and vomiting. So most providers recommend that you should shoot for a normal level, and that normal level varies depending on which lab you're having your blood work done at. Vitamin D can come from multiple food sources and mostly comes from sunlight exposure as well, though many of us in the day and age that we live in don't get enough sunlight exposure, even in Colorado on the sunniest days. And so many people still have low vitamin D levels and need a supplement to get up to those normal levels. Other vitamins and other supplements have also been looked at. Vitamin D is the one that has had the most consistent data to date. Infection risk, as we touched on briefly earlier, has been a huge source of interest as far as what infections we're exposed to growing up and can those affect our rate of MS prevalence. EBV is the one that has been of highest interest as of recently in the literature. And I'm going to refer to the 2022 paper that came out in Science. This was a longitudinal study looking at members of the military and their rates of going on to develop MS. So it takes a whole bunch of people and follows with annual blood samples and looks for markers, looks for a bunch of different markers and going on and tracks to see, okay, who ended up developing MS and who didn't. So it ended up having 800 new diagnoses of MS patients within their sample and 1,500 controls. So a good number of patients that they were able to look at. However, on a smaller scale, of those 800 MS patients, only 35 initially were EBV negative at that very first blood draw, so even before they were diagnosed with MS. 34 of the 35 ended up having an EBV exposure and had an EBV infection and seroconverted. So markers of EBV became positive in their blood prior to the MS diagnosis. The one patient who did not have a clear EBV seroconversion, last blood work was about 1 year prior to MS diagnosis. In the graphs that you can see here, I've included their comparison between EBV and CMV exposures and the seropositivity. And so what this graph is showing is that the green lines are patients with MS and the blue lines are patients without MS, your control population. And you can see that among the control population, as you follow different samples, you were much higher. There was a difference between rates of seropositivity of EBV in those that had MS and those that didn't, versus in CMV, those rates were pretty similar. And that's the same thing that this graph is showing here. One graph that I didn't include is that neuroinflammatory marker. So neurofilament light chain, which is a marker that we know is a generalized marker of inflammation, was also checked in these patients, and markers increased after an EBV infection. So there were signs that EBV can trigger neuroinflammation in general. There are a lot of thoughts as to what could be going on to cause why EBV may go on to trigger that. Molecular mimicry is a theorized and hypothesized mechanism as to why this may happen. And basically what that means is that when EBV infects the cell, it produces an antigen on the immune cells, or the B cells, that then cause it to react. And the way it's supposed to happen is that it produces those antigens. And so if EBV presents itself again, your body can recognize it and attack EBV to prevent you against having a more significant infection. Unfortunately, the thought is that EBV antigen can mimic your own protein recognition. And so that's the thought, is that something on myelin looks like an EBV antigen, and that EBV antigen can mimic myelin, then leading your immune cells to attack your neurons. On the right-hand panel, this is kind of the model of what molecular mimicry means. The right-hand panel is some of the data that has come out recently in Nature and Science papers looking at the molecular structure of some of these EBV antigen and proteins that are produced, and looking to see if molecular mimicry is possible. One of the tricky things with EBV infection is that many of us have been exposed to EBV. So the graph on the right shows, this was from Europe, produced in 2020, and looks to see by ages what proportion of the population was EBV seropositive. And so you can see by 5 years old, it's something around 70% of their population was already had an EBV infection. And by the age of 2025, your young adult years, it's somewhere around 95% of the population. And so that's why those samples of the people who were initially EBV negative is just so small, because most of us have been affected. You can see that there were no significant rates and differences between males and females as far as when EBV infections occurred overall. So the thought with that is that EBV likely is another of those risk factors that, again, increases your overall immunogenicity and increases your risk of MS, but that it's not enough by itself to ultimately lead to an MS diagnosis. We know that your risk of MS increases about 32-fold after EBV exposure. So what that means is that if you are one of the lucky 5% of the population that has not had an EBV exposure by the time they're 25, your risk of going on to develop MS is very, very low. But it doesn't necessarily predict who is going to go on to develop MS. There is interest in vaccine development at this time. At least as of now, there's no indication to clearly say that a vaccine would help with either progression or prognosis of MS in general once MS has occurred and has been diagnosed. But there is thought that if it could be given early in childhood, potentially we could decrease that 32-fold risk after EBV exposure and significantly decrease the prevalence of MS overall. Other factors that have been studied and that are known to have an effect on MS include obesity. So we know that obesity is associated with increased risk of MS development, starting even in adolescence and continuing into adulthood. And we know that obesity is also associated with increased inflammation in general, and has been associated with increased relapses and disease progression. So the two graphs that I'm showing here are graphs looking at overall progression scales. So for those people who have participated in research trials, they may have heard the term EDSS. For those that have not, EDSS is one of the scales that we use to look at disability in patients with MS. And you can see what this one is looking at is a not restricted EDSS, so a 3 or less. So this is basically people who are the percentage of people who have a very low disability score. And your rate of having a low disability score was better if you had a lower BMI compared to a higher BMI. And that changed with time. So you had an increased risk with time of that continuing to decline. And that's the same thing that this graph shows. Along with that, many people ask us about, are there ways to control our diet in MS, and can diet alone be effective enough to treat MS? So there have been a couple diets that have been studied and that are in the literature. The Swink diet and the Wall diet are two of the more common. Wall's diet has some data to show that potentially improves fatigue, but has not been shown to clearly affect relapse rate or progression of MS, and is very difficult to adhere to. So somewhere around 50% or more of patients who initially were trying to adhere to that diet ended up not being able to complete it for longer than a couple of months at most. One of the other factors that we look at is our different food groups. So things that are thought to be more inflammatory, like dairy or gluten, can those have an effect in MS? And NITA is another marker of progression and overall function, and there was no significant difference in disability status between patients that had dairy or did not, or had gluten and did not. So elimination of those factors from diets did not seem to be beneficial. The Mediterranean diet has been shown to have some benefits in symptom severity and mental health indices. So again, these diets and eating healthy are overall felt to be beneficial as far as general well-being and continue to help with symptom management, but have not been shown to actually alter the course of inflammation or the prognosis of MS long-term. Smoking is another big one that I want to hit on. Smoking and secondhand smoke exposure has been known to significantly increase risk of development of MS. So in pediatrics and adults, it's been shown to have at least a 2 times more likely risk of a development of MS if you have been around, if you are either a smoker yourself or have been exposed to secondhand smoke. We know that if you have received a diagnosis of MS, that it can also have a significant impact on both disability and progression. So you have an increased risk of primary progressive MS in smokers compared to non-smokers. You also have an increased risk of clinical relapses and enhancing lesions on MRI, higher level of disability and shorter time to needing assistive devices for walking, and an increased risk of progression to secondary progressive MS by 4.7% per year of smoking. So if you are not a smoker or quit smoking, the on average delay to secondary progression was about 8 years compared to patients who have MS and continue to smoke. So definitely something that if you're struggling with, because we recognize how hard quitting smoking can be, continue to work with your provider and see what supports you may be able to receive, as this is something that is a modifiable risk factor that you can do that can increase your chances of continuing to do well without progression of disability. There have been a lot of questions as to other factors that may be contributing to MS diagnoses. And I just kind of wanted to list a few others that have been talked about that have not shown any clear evidence of impact at this time. Chronic stress is one that's of high interest, something that I find really interesting, as well as I work in the pediatric side as well, is what are the stresses of childhood or the chronic stressors that people explore and are experienced too. How does that affect your risk? Overall, there's some data coming out that shows that that stressors can affect relapse rates, but overall your risk of development of MS is not consistently shown to be increased in studies that have looked at chronic stress. The most recent review I can find of this is from 2022 and still had a very small sample of studies that was reviewed. And so I think there's a lot of room to be explored in this area. But at least as of now, no significant impact. Heavy metal exposures, environmental allergens, and organic chemical solvents, so things people are exposed to either in their neighborhoods or at their jobs, has also had interest and been studied without clear correlation and without clear causation as far as worsening impact of MS at this time. Vaccine use as well, especially with all of the changes in the last couple of years. There have not been any clear risks of MS with regards to timing of vaccinations to date. And then one of the more ongoing areas of interest in immunology in general is gut microbiome and what that microbiome, those differences. Are there any bacteria that live in our gut that promote MS or are protective against it? So far, no clear data from that, but ongoing research is happening at this time. So take-home points, hopefully, that this webinar has touched on is that MS is a complicated diagnosis that doesn't have one simple etiology. Genetics definitely has a role in a predisposition to increased risk of MS development, but by itself cannot explain why multiple sclerosis happens. There are multiple environmental triggers that come together to play a role. And it's thought that once you reach kind of a threshold that enough of these factors, genetics, environment, all come together, that then the immune system becomes inappropriately activated and starts attacking myelin, and that's what leads to the diagnosis of MS. Included some of the research opportunities that are available. So for those, I know that it expressed questions as far as if my family members are interested or what testing may be available. The Rocky Mountain MS Center and UC Health are currently participating in Rise MS and Dreams, which is looking for genes, biomarkers, and environmental circumstances in families. So looking primarily at first-degree relatives, so parents, siblings, or children between the ages of 10 and 30 years of age to see are there risk factors to diagnose and treat MS as early as possible. And can we help create, can we help look at a profile to say someone may be more at risk than others to help potentially with earlier surveillance and earlier treatment. There's also biorepositories that are available and ongoing looking at different inflammatory markers, both from plasma and blood collections primarily, and also if someone is receiving a lumbar puncture from spinal fluid to look at what different markers may be present that could help signal earlier diagnosis of MS. Many references that I've included. And I think we still have some time for questions.
Wonderful. Thank you so much, Dr. Moehlman, for all of that fantastic information. We are going to move into our Q&A portion. Again, we had a large volume of questions submitted at the beginning, and I will be grouping similar questions together. Many of the submitted questions were answered during the webinar, and I'm going to try not to repeat any information, but again, you can access this archived webinar and replay any parts that you missed. And then just a note that we're unable to answer overly specific or situational questions, as this webinar is just for educational purposes and is not medical advice. All treatment questions and decisions should be discussed with your own medical provider. So with that, we will get started. When you discuss the risks of smoking and MS, where does vaping nicotine fall into that?
Great question. So with the vaping and nicotine being on the newer side, there isn't as much data in general, but nicotine itself in the past has been shown to have a pro-inflammatory component. And so we would caution against it and recommend, if able, to work towards coming off of that.
We had a lot of questions submitted about related, or is there a relationship between MS and other autoimmune conditions, RA, type 1 diabetes, et cetera, Hashimoto's. Can you talk a little bit about that? We had a lot of folks who had a lot of different autoimmune diseases in their families.
Yeah. So we know that immunologic diseases in general tend to be more common together. MS, to some extent, actually has a little bit less of a risk of overall associations with other inflammatory conditions compared to some of the other more systemic causes. And that's thought to be because the blood-brain barrier has a little bit more of a protective effect. However, that being said, there is an increased risk in general. And so that's something that usually your provider should ask you about, especially if we're trying to figure out the diagnosis, does anyone in your family have MS? Does anyone in your family have these other conditions? I always like to say MS doesn't necessarily predispose you to having those other conditions. If something doesn't fit, we always like to go looking and make sure that nothing else is going on and that nothing else is contributing. But we know that overlap does happen. And so we try to do our very best to find medications that can help treat both. And a few examples in patients with MS and rheumatoid arthritis, rituximab has been shown to be helpful in both. And so that's something we will sometimes use. Ulcerative colitis, one of the forms of inflammatory bowel disease, and MS can also both be treated by siponimod as an indication for both of those. And so sometimes if those diagnoses coexist, we can try to medication management to minimize number of medications and maximize what treatments you can get from those.
We have a lot of interest in the smoking questions, actually. Is it any smoke that contributes to the risk? Would like campfire or wood smoke also count?
So campfire and wood smoke, the difference is that you're not inhaling as much directly into your lungs, can increase it to some extent. It's also that it tends to be more that chronic smoke exposure. So I would say an occasional campfire is totally fine. And I want you to continue to get to enjoy activities and live normal life. It's more that kind of day in, day out smoke exposure that definitely leads to increased immunogenicity.
Another hot topic that we had a lot of questions about is what about if I'm a parent who has a child? Is there anything that we can be doing to protect our children? Is there something we should look forward to? What should I look for as they get older?
Great question. And again, something near and dear to my heart as the pediatric side as well. So I think a couple of those modifiable risk factors are things to think about. The ones that I think are pretty easy to do overall is a vitamin D supplement. Most of us are vitamin D deficient, and something that's relatively easy. Again, I don't want crazy high levels of vitamin D, but a normal level. And so I think taking a multivitamin for your kids, making sure that if that multivitamin has vitamin D or not, that they're getting some sun exposure to try and help, as we know that low vitamin D levels does increase your risk of going on to develop MS. Continuing to try and encourage healthy habits as well, as we all struggle with obesity in this country, is something that we can work towards to just overall decrease general inflammation as well. And then if you're interested in research and more testing and things like that, getting involved in some of these Rise and Dream studies that are available can be a great way to have some additional access to studies. But at least right now, there's not enough evidence to say that routine MRI screenings in relatives that don't have any symptoms is warranted. Now, if symptoms develop, classic symptoms of MS, things like vision loss, numbness, weakness, the things that that your providers are counseling you to look for as far as relapses develop in your loved one, making sure that the providers who are taking care of them know that you have MS so that they can consider that and look is important.
Is there research being done around aquaporins being a cause or worsening of MS?
So aquaporin 4 is a separate diagnosis. So aquaporin 4 and is associated with neuromyelitis optica spectrum disorder, which is used to be thought of and used to be lumped under MS, but is now known to be a distinct entity on its own. So right now we don't have antibodies to test for MS directly. We have antibodies to test for two of MS, what we call mimics, or things that can look like MS but are different. And the two that we have, one is called aquaporin 4 and looks for what has been associated with NMO or neuromyelitis optica in the past, and the other one is called MOG antibody or myelin oligodendrocyte antibody and associated with MOGAD. And those have different responses to immunotherapy, different disease progressions, and different mechanisms behind the immunogenicity itself, which is why they're considered distinct entities at this time.
You mentioned that there hasn't been a clear connection between stress causing MS. Can you talk a little bit about the role that stress might play in triggering MS or unmasking MS?
So stress, there are some studies that show that stress has an impact on relapses or worsening of symptoms of MS. We know that anytime you're under physiologic stress, it can be a combination of things. One, old MS symptoms are more likely to appear, but also there may be a slightly increased chance that new symptoms can appear as well. That's why it's important to continue to work with your provider to see if there are new lesions that are present that can be causing, or if it's those unmasking of old symptoms that can be coming up. As far as stress regards to occurring before the initial MS presentation or the initial MS symptoms, the data on that is still really poor at this time. We need more research available into that area.
Which genetic issues seem to be most related to primary progressive MS? Transporter issues, fatty acid disorders, methylation? Why do some people get remitting MS versus progressive MS? I know you touched on that a little bit.
So I touched on that a little bit. I can speak to a little bit more. So at least so far, there have been none of the 233 genes that I mentioned. There have been none that have been clearly associated with primary progressive MS versus relapsing remitting MS. So it's unfortunately really hard for us to say right now. That is a huge area of interest, both because it affects how we can make diagnosis and it also may affect treatment, but at least as of right now, the mechanism behind why that happens is not well understood and is thought to be potentially more due to how much of the astrocytes are actually affected, how severe the damage is, and also potentially where damage occurs. And we don't have a great answer as far as why certain areas of the brain or spinal cord get targeted over others.
Let's see, what relationship might exist between MS and other B-cell disorders like blood cancers, in addition to the autoimmune disorders that you already discussed?
So seem to be different entities and different genes that affect. There's been a lot of interest to see if changing the B cells when we have B cell depletion therapies has any cancer risk, and at least so far that's not played out in large scale studies. So affects the same blood cells, but seems to affect them in different ways.
And I think as far as the non-specific questions go, that is all that we have for today. And I know we're running short on time, so I'm going to go ahead and wrap us up. But thank you, Dr. Moehlman, for all of this great information. Thank you, everyone who submitted questions ahead of time. And I hope everyone has a wonderful rest of their afternoon.
Thanks for joining, everyone.